This audio PowerPoint and then the lecture portion that we'll get to in class next week is going to talk a little bit more about rehab following orthopedic surgery and where we as the physical therapists fit into the equation. So the objectives particularly of the voiceover or the audio PowerPoint is we'll talk a little bit about soft tissue repair, which hopefully should be reviewed. We'll talk about how that pertains to orthopedic surgery. And then in class we're going to talk a couple of key orthopedic surgeries, a little reminder about the anatomy, the actual surgical procedures out there, and then rehab considerations. And at that point we'll be looking for input as regards to rehab protocols and how you feel that these patients might be managed. When we think about soft tissue repair, what we know that the healing response depends on the tissue type. We're aware that there's variation between, for example, how muscle might heal versus how tendon might heal. And both intrinsic and extrinsic factors can affect that healing process. So some examples of an intrinsic healing factor might be, for example, where or how much blood supply that area might have. That'll certainly influence the healing. Whether that patient has diabetes, maybe the age of that patient, location of the tissue. If that tissue is an area of high stress, it's going to be more challenging for it to heal. Extrinsic factors to consider are things such as temperature. Ideally, you want body temperature to allow optimal healing. If there's issues such as infection in that area, if that's developed, that's going to affect healing. As will medications. If you think about the role of maybe steroid medications or an anti-inflammatory medication, sometimes they can slow down the natural or the normal healing process because they affect the development of inflammation and that process that is required for healing. So just be mindful of all these factors as you consider the healing of a tissue. So when we think particularly about the repair of epithelial tissue, such as described here or shown here in the diagram, you've obviously got the initial stage, that's that coagulation phase, and that's right after the incision. And typically here you're going to have initial vasodilation. You're also going to have an aggregate of platelets coming into that area. The second phase is the inflammatory phase, and that can last for several days. And here we're going to have more vasodilation, and you're going to get phagocytes, in other words, the cells that are designed to come in and basically clean up the debris from the trauma. They're going to come in and clean out the area so that the approximation of the wound sites can occur. The next stage is granulation, and then you're going to get fibroblasia along with wound contracture. So you're going to starting to get that closure. And then finally is the scar phase and maturation. And here we're going to get collagen synthesis, and this can last from several weeks to several months and even sometimes several years. So just to be mindful of the duration of that scar formation phase. So when we think about what a wound requires, it requires a clean environment. So one of the things you might be considering doing when you get a patient in for rehab is you may be looking at the wound. Does it appear to be clean? Is there any unusual drainage? How's the circulation? Some of the exercises that we might do might help improve circulation to that area. Thinking about approximation of wound edges. In the past, we have seen patients who've had metal sutures, and we've seen actual thread or twine sutures, but now we're looking more and more, we're seeing areas where wounds are closed with glue, and the healing response for that may be slightly different, so it's important to be aware of that. And then when we think about chemotaxis, we're thinking about, in this case, in the situation of wound healing, is we're thinking about the proper immune response in the wound environment. In other words, the movement of the cells towards the healing area. So those are all important things to consider when you think about what healing needs. So we think about scarring. Patients often have concerns about it. It is the normal thing to do. I'd be more worried if a patient didn't have scar tissue, because that means then we're not going to get closure of the site. Really should be minimal, though you will see patients who tend towards keloid scarring. Very often if they've had scars before, they'll be aware that they do have that keloid or that thickened scarring. Scarring can be influenced by age. Obviously, younger, healthier population tend to lay down scar tissue more quickly in a more systematic way. Also thinking about metabolic activity. Is there any other medical comorbidities the patient is dealing with that may be affecting the ability to lay down scar? Hydration. So important. Our patients after surgery drink plenty. It's very easy in the hospital for them to avoid drinking, and so it's really, as a therapist, I really make a point every time I visit a patient's room to make sure that they are drinking, as long as that is allowed per their MD instructions. And then lastly, smoking. I know Sam's alluded to the fact of smoking can affect tissue healing, so that's something you want to be mindful of interacting with a patient who has a wound that may slow down. If the patient is a smoker, it may slow down the healing process. When we talk about ligaments and we think about tissue repair, we've mentioned before, not great blood supply. We've talked about our grades 1 through 3, so you should be familiar with what the differences are between those. Ways to quantify injury, for example, you've got the KT 1000. We mentioned this when we spoke about the knee, and this is a device that's used to assess ACL stability, and it quantifies that translation of the tibia relative to the femur. Obviously, we've got our test, the Lockman's test. When we think about healing of ligaments, you want to think about the three phrases here of inflammation, proliferation, and then remodeling. And they're all important in that repair. So key things here, the timing of post-injury mobilization. And what we know is that as somebody responds, that too long of immobilization can be detrimental as much as mobilization too quickly. In the past, with an ACL injury, a patient was often placed in a long leg plaster of Paris cast and left there for several weeks, maybe even up to 8 weeks in duration, and they really had a problem then after that moving because there had not been any stresses on the ligamentous structures. So timing is key, and what we have found over the years that these longer sort of immobilization periods have been decreasing in length as the researchers supported the fact that patients who are mobilized sooner have better overall outcomes. Much of the research that's been done on immobilization and then mobilization has been done in animal studies in rats and rabbits. In particular, one study that they looked at, and one of the ligaments that's most frequently examined in research studies is the medial collateral ligament, whether it be a rat or rabbit. A particular study found that when they looked at where the medial collateral ligament had been transected, and then after 2 weeks that particular group of rats were placed in a relative immobile state, just being contained to cage activity, versus a group of rats who were then placed on a treadmill, those who were sacrificed and then examined at 8 weeks, they found that those who'd had the increased activity, the treadmill activity, those are the ones that ended up doing much better, and they had much more a greater increased tensile strength of that medial collateral ligament when it was stressed. Again, some of the challenge are with this research having been done on mainly rats and rabbits is the extrapolation to humans, and obviously we need more trials on human beings. So do we know the optimal duration for mobilization? No, but you are seeing that we're shorter durations of immobilization as compared to previously performed. So if we think about tendons, we have talked a little bit again about the fact that tendons don't have great blood supplies. Direct injury, such as a laceration to a tendon, perfect example would be in some of the wounds that occur to the hand. And indirect might be more so, such as a tensile overload like an Achilles tendon rupture. Avulsion fractures and then ruptures at the myotendinous junctions are more likely than mid-substance, and I always think about the quad when I think of this, and the patients that I've seen who have ruptured that junction between the distal quadriceps and then the quad tendon versus the quad muscle belly itself. And mid-substance ruptures are more often associated with pre-existing, and that makes me think of those patients who I've treated who've ruptured an Achilles tendon. Again, they've traditionally had more of a history of a stiff Achilles, maybe Achilles tendinopathy in the past, and then the rupture was the final straw for them. With the healing, it kind of breaks down into two groups. You've got the paratenon covered tendons, and then you've got the tendons that have more of a sheath over them. The peritoneal tendons tend to follow the traditional inflammatory, proliferation, and remodeling phases. The sheath tendons don't have as good a blood supply, or even a worse blood supply, I should say, than the peritoneal covered tendons, and they, as a result, their ability to recover is much more controversial. What we know with the role of mobilization, that motion and stress increase collagen production and accelerate healing. We know that if we stress the tissue, that overall resolution of function is going to be higher. I think that was pointed out when we talked a little bit about some of the post-op protocols that are available for Achilles tendon repair, and those patients who had earlier motion were able to resume functional activities. Just a brief comment about soft tissue repair in muscle. As we know, skeletal muscle's got a fairly good blood supply, and we can think about direct contusions and muscle lacerations. You think about somebody getting trauma to the quadriceps, hamstring muscle. You can also get indirect or overloading, more often thinking about our biomechanical limitations. There is limited healing capacity. Though muscle has got a good blood supply, it doesn't tend to differentiate back into muscle tissue, but rather we get the formation of scar tissue, which has the capacity to fill the gap or to replace the traumatized myofibrils. However, the challenge is that scar tissue does not have the same elasticity as the pre-existing muscle that was damaged. So potentially it lies as a point of weakness, and then as a result, certainly with a larger insult, you're going to get plenty of this scar tissue filling that gap. Again, you've got the phases of inflammation, proliferation, and fibrosis through here. I think a couple of things just to keep in mind when you think about soft tissue repair. We've talked a little bit about contusion, so just somebody simply getting trauma to the quadricep, other muscle groups. Lacerations, the ability for the area to fill with scar tissue. You're familiar with this term delayed onset of muscle soreness that comes particularly after eccentric protocols. Patients will have that soreness a day or two afterwards, which is thought to be associated with some micro tearing of the fibers, the myofibrils. And then myositis ossificans, you may see this in some of your patients, and it can be a little bit of a challenging condition to deal with. And typically it's related to ectopic calcification fibroblasts, and they basically form bone cells in the muscle belly itself. The actual treatment is rest. At times the human body can self-reabsorb, and occasionally these patients might need surgery to remove that area of bony growth. But again, I've seen it before in patients who have had pathology around the elbow, so that tends to be a group you want to be mindful of it. And also in the quadriceps, these patients can, with trauma, develop some ossification in the muscle belly. So just to be aware, first line of interaction is rest for these people. So when we think about surgery, so we've talked a little bit about some of the different ways that tissue heals. We think about surgery, and I like this definition, controlled trauma produced by a trained professional to correct uncontrolled trauma, which is a really nice way to think about what's been going on with the patient, leading them to have surgery. So immobilization, which is part and parcel very often after any surgical procedure. Again, I mentioned before in this audio PowerPoint that very often a lot of this research has really been done on animal models and not on humans. What we do know, when they've actually observed the tissue under microscope, that you get the fibrofatty infiltrate into the areas around the immobilized tissues, in other words the fibers. You get adhesions, you lose glycosaminoglycans, and then obviously the water that goes with it. And then what we tend to find with the soft tissue is you're going to get less tensile strength, so they will fail more quickly. So limitation of immobilization is that we end up with a soft tissue that doesn't have the same tensile strength. So the goal of remobilization, or what we're in the business of, is preventing the haystacking. So if you think, I often describe this to my patients a little bit like healthy tissue or healthy muscle or ligament is a little bit like spaghetti in a box, where the spaghetti fibrils are lined parallel to each other. When you have an area of scarring, what you tend to have is a bit more like cooked spaghetti, in that you have that sort of interwoven activity of the fibers, and they're not aligned in that nice parallel orientation. So this idea of haystacking, the idea is that we want to do away with this sort of intertwining of the fibers. And through remobilization, we can also produce or stimulate the production of ground substance. We come to the idea of this orderly laying down of the collagen in the directions the forces are applied. So it's important as a therapist understanding the anatomy, understanding the healing process, to know what exercises or what particular stretches will be most useful for a patient to augment the restoration of length of those collagen fibers. And then obviously macroadhesions that are formed during the immobilization can elongate and partially rupture. That can be a little disconcerting for patients. I've worked with patients before who have had maybe, for example, rotator cuff surgery. They've been immobilized, and as we're starting to mobilize their shoulder, they can feel something pop. And it really is a little concerning. Patients start to think, oh my goodness, that the repair has torn, and very often it is just a microadhesion, an area where they've had a lot of scar tissue laid down, that has just released and has given them that pop. Just something to be aware of as you're working with patients who have been immobilized for a period of time. And then just thinking about guidelines for dealing with scar tissue after surgery. As you assess the patient, be mindful of where is that patient with, how long ago was the surgery. And the person who'll know what kind of work was done internally and the challenges for creating a closure will be the surgeon or referring physician. So make sure that you communicate with them just so you know what you're dealing with. Recognizing the window for mobilization. It's really hard for patients who are in pain to want to move. They're fearful that they may redamage the tissue. And really what you've got to do is encourage them and remind them that they have a window of opportunity where the body will be flexible as regards to regaining their normal range of motion, and that really that window needs to be used versus waiting too long to start actual mobilization. Again, on the other side, we do need to be mindful of the fact that with the tissue healing, there is a time for mobilization, and we do need to not start that too soon. So again, I think the key is communication with the other referring sources as regards to the appropriateness of mobilization. So again, timing is key. Just to finish up here, as we consider mobility work, we think of the mechanical, we think about the alignment of the fibers, we think about potential for a neurophysiological effect. The focus is on getting back in water into the area. We think about reducing the adhesions or cross-linking. The plastic deformation, in other words, that load, the stress and strain, thinking about your curve there and changing the relationship. We want to optimize the length of the collagen fibers so that joint or that tissue can work through functional ranges. And then obviously the role of mobility work, whether it be manual therapy, whether it be flexibility the patient does, we can increase blood flow, lymphatic and venous return, and obviously cellular metabolism, which is so key for that normal healing process to occur.